he had a gallaging fracture. So the challenge was the patient presented with significant surgical burden and the major long bone fracture concurrent with the complex forearm fracture and dislocation, which we call the gallaging fracture and dislocation. And this is the X-ray of the femur, the sharp femur, mid-third fracture, a 17-year-old gentleman, and the forearm gallaging fracture, severely displaced fracture. Inner canal, it was narrow, so the nailing was difficult. The standard treatment is nailing, and ideal treatment for this gallaging fracture is the plating. But I opted nailing, although it was difficult nailing in the both fracture and the slight distraction, the tense nailing for gallaging fracture, and this is not reported in any literature for such a severely displaced fracture. The tense nailing should be considered. In fact, there is no literature present for the tense nailing for this type of gallaging fracture. So we did for the minimally, because it is minimally invasive, and periosteal and endosteal blood supply are maintained in both fracture, and the interlocking nailing was done in the sharp femur, and only 9 millimeter nail could be negotiated because the narrow medullary canal. So there is slight distraction, as you can see in this picture, but we did locking. It was difficult nailing. So the goal was to provide sufficient stability for early mobilization despite of an anatomical constraint, and implant was 9 millimeter nail, and technique was minimally invasive. And whereas in this left radius, the gallaging fracture, we did tense nailing. In this case also, the 2 millimeter tense nail was used. Usually you use a 2.5 millimeter tense nail, but we use 2 millimeter tense nail. Still there is distraction at the fracture site. So this was the problem with this due to the narrow canal. But this is the 6-month follow-up. You can see I sent this X-ray in Indian Orthopedic Research Group, IORG, and they told to revise this case. Provide stable fixation and earlier mobilization and reduce the risk of non-union marking. Hence, is less invasive, resulting in smaller incision. Conducted a study between March 2020 to March 2025 on 25 cases of the displaced fracture of the clavicle. The age of the patient was 16 to 48 years, and no comorbidity was found in our study group. All patients treated with titanium elastic nailing. So the road traffic accident was the main mode of the trauma, whereas the fall from height and the fall on the outstretched hand was the other mode of the trauma. So the typical mode of the trauma, this picture is taken from the AI, and this is the fall on the shoulder to protect the head injury in mode of trauma. And this is the typical presentation, a bump at the fracture site, and the skin appears as if the skin will penetrate the fragment will penetrate the skin. So the radiological, typical radiological picture, you can see the severely displaced fracture, 2.5 centimeter, a jet type of fracture, jet type of communicate fracture, and the other indication for surgical treatment is the floating shoulder. So these are the typical presentation as well as the radiological presentation and the mode of the injury. And we included the simple fracture only, 15B1 and 15B2 according to AO classification. The 15B1 is a spiral and oblique, where 15B2 is a transverse and short fracture. So the patient lies supine with affected, please elevated, and handling outside the table so that the reduction can be done by doing abduction and external rotation of the shoulder. So incision is 1.5 centimeter lateral to the sternoclavicular joint, and after making incision, we make a hole with the help of the drill bit or the bone out. But this is a crucial step. One should be very, very cautious because the heart and the lungs are like vital structures are waiting for your instruments to escape. So this is a very crucial step, and then make this hole continuous with the intramedullary canal of the clavicle, and then we did close reduction or mini incision reduction, and then titanium elastic milling was done after reduction of the fracture. So the post-op protocol or immediate post-op, we did pain management and immobilization of the limb at the 2 weeks, the wound inspection and the suture removal at the 6 weeks, the radiological follow-up for the fracture healing, and by 12 weeks, the functional assessment of the fracture healing, and finally, if required, the implant was removed at the 12 weeks. The 6-month final follow-up was 20 to 50 ml in all our cases. So the post-operative observation, excellent results, 76% of patients, whereas the good results were found in 16% of cases, whereas the 4% was the figure for the failure as well as the poor results. So the complications, the nail back out, superficial infection, and malunion, each had 4% figure, and the hardware irritation was 8% in all our cases. We have few cases. The radiological as well as clinical picture, as you can see, this is 15B1 fracture, and treated by titanium elastic nail, the post-operative case, and the beautiful surgery has been done. You can see the one stitch surgery, no instrument was used to reduce the fracture, only the thumb and the index finger was used to reduce the fracture, and abduction and external rotation of the shoulder was used to reduce the fracture. But this does not happen always. Many times we require the mini open reduction of the fracture. So this is another case we did, the 15B1 fracture and treated by titanium elastic nailing. You can see the 6-month follow-up, the beautiful union, the secondary union. There are 2 bumps in the clinical picture. You can see at the fracture site there is secondary callus formation. One bump is due to secondary callus formation, and other at the entry site you can see that there is hardware prominence. So this is another case of the mid-third fracture treated by titanium elastic nailing. Yet another case 15B1 fracture treated by titanium elastic nailing. Yet another case of 15B2 fracture treated by titanium elastic nailing. And this is again 15B2 fracture treated by titanium elastic nailing. And this is 15B3 fracture. Ideally, it should be treated open reduction and internal fixation with a plate and screw. But we did titanium elastic nailing in this case also, and you can see that the beautiful union of the fractures at the 6-month follow-up period. So this is the functional result. And the limitation of this surgery, a number of cases included in this study was small and the short period of follow-up, and this is the retrospective duration, and a prospective study is required to establish this treatment as the attractive modality of the treatment for the mid-third fracture of the clavicle. So the take-home message is TENS snelling is effective for the clavicle fracture with good to excellent results, the minimum complication with properly selected patient and properly technique performed. So the further studies are needed to confirm the long-term efficacy of this modality of treatment. So thank you very much for your patience here. ये फ्रैक्चर है टिबिया का, कई भागों में विभक्त है और इसे डॉक्टर ठाकुर इनोवेटिव टेक्निक ऑफ सुप्रापेटलर नेलिंग ऑफ टिबिया के द्वारा ऑपरेशन किया जा रहा है। इस वीडियो में देख सकते हैं कि गाइड वायर को डाला जा रहा है और गाइड वायर फ्रैक्चर रिडक्शन के बाद परक्यूटेनियस फोर्सेप्स के द्वारा बिना चीरा लगाए रिडक्शन फोर्सेप्स के द्वारा उसे रिड्यूस किया जा रहा है। और रिडक्शन के बाद मैलिएबल गाइड वायर को सीआर के मदद से डाला जा रहा है और उसके बाद उसे मेडुलरी कैनाल को रीम किया जा रहा है और रीम करने के बाद नेल को गाइड वायर के सहारे सीआर के मदद से फ्रैक्चर को रिड्यूस पोजीशन में रखते हुए नेल को डाला जा रहा है। एक उचित साइज के नेल को सेलेक्ट करने के बाद उसे डाला जा रहा है। फ्रैक्चर रिडक्शन परक्यूटेनियस रिडक्शन फोर्सेप्स के द्वारा किया गया है। और अब नेल को डाला जा रहा है। हम नेल को फाइनली लोअर एंड ऑफ द मेडुलरी कैनाल डालने के बाद उसे अपर फ्रैगमेंट और लोअर फ्रैगमेंट को लॉक किया जाएगा। आप देख सकते हैं कि किस तरह से फ्रैक्चर का रिडक्शन हुआ है। ये है RCT नेल इंट्रोड्यूसर कंपोजिशनर, जिसके द्वारा नेल को डाला गया है और अपर और लोअर फ्रैगमेंट दोनों को फ्री हैंड टेक्निक से सीआर के मदद से गोल करने के बाद होल को गोल करने के बाद इस तरह से सीआर को एडजस्ट किया जाता है कि होल गोल दिखे और उसके बाद उसे ड्रिल करने के बाद उचित साइज का स्क्रू डाला जाता है। देखिए बिल्कुल गोल दिख रहा है अपर फ्रैगमेंट का दोनों होल और उसके बाद स्क्रू डाला गया है। गोल दिख रहा है, स्क्रू डाला जा रहा है, अपर फ्रैगमेंट के लोअर होल में डाला जा रहा है। फाइनली दोनों स्क्रू को उचित साइज के स्क्रू को अपर फ्रैगमेंट में लॉक कर दिया गया है नेल को और अब लोअर फ्रैगमेंट के एंट्रोपोस्टीरियर जो होल है उसको गोल किया गया है। इस तरह से सीआर को एडजस्ट किया जाता है कि वो गोल दिखे और
एंट्रोपोस्टीरियर स्क्रू को डाल दिया गया है, जैसा कि आप पिक्चर में देख सकते हैं। और देखिए अब मेडियोलैटरल होल है वो गोल कर दिया गया है, इस तरह से सीआर एडजस्ट किया गया है। और अब मेडियोलैटरल स्क्रू को भी डाला जा रहा है। ये मेडियोलैटरल स्क्रू डाल दिया गया है और एक लंबा सा स्क्रू जो आप देख रहे हैं वो एंट्रोमेडियल स्क्रू है। ये तीनों स्क्रू लोअर फ्रैगमेंट में दिख रहे हैं। इस तरह से लॉक किया गया है बिना चीरा लगाए, छोटा छोटा चीरा जस्ट स्क्रू घुसाने के लिए रॉड में। और ये फ्रैगमेंट फ्रैक्चर है, आप देख सकते हैं कितना बढ़िया रिडक्शन हुआ है। 3 भाग में टूटा हुआ था। ये 3 लोअर फ्रैगमेंट का स्क्रू है, आप देख सकते हैं कितना बढ़िया अपर फ्रैगमेंट का स्क्रू है। ये RCT नेल इंट्रोड्यूसर कंपोजिशनर के द्वारा डाला।
Hello friends, today I am going to give a demo of interlocking nailing in fracture shaft femur lower third in a 72 years old female. This patient sustained this injury due to fall on the ground. Usually this fracture occurs due to high velocity trauma in young adults, either due to road traffic accident or fall from height. But in old age, this may happen in a trivial trauma due to fall on the ground. So let us come to the demo of this surgery. This is the X-ray of the same patient having lower third short oblique type of fracture of the shaft femur. As you can see, in the other limb, the patient has been operated, that is interlocking nailing has been done 4 years back for the fracture of the shaft femur. So this time the patient had come to me for the lower third fracture of the shaft femur or other limb. So let us come to the surgery. First of all, I will make an incision just above the greater trochanter, about 2 to 2.5 centimeter diameter, and then after blood dissection of the tissues, I am introducing a bone out just medial to the greater trochanter in the piriform fossa in APU. As you can see in the CR picture, and in lateral view, it is at the junction of the anterior 2/3 and posterior 1/3 of the greater trochanter. As you can see in the CR picture, I am having the bone out inside the intramedullary canal so that it can enter in selected exact entry point. And this is the lateral view. You can see that it is at the junction of the anterior 2/3 and posterior 1/3. You can see in the picture, and epi view, this is the lateral view, this is the epi view, and this is the lateral view. Again, I have focused to confirm the entry point. And finally, after confirming in the CR picture the correct entry point, I am introducing by a screen movement of the CR, and you can see that this is the epi view. It has gone in correct position, and in lateral view also it has gone in correct position. That is at the point of the anterior two-third, at the junction of the anterior two-third and posterior one-third of the retrocenter. So after confirming it, I am going to introduce still I am introducing the bone out inside the intramedullary canal, and finally a 2.5 millimeter guide wire is being introduced inside the intramedullary canal, just lateral to the bone out, which has been pulled out to make an space in the lateral part of the bone out to introduce the guide wire. And finally, after introducing the guide wire, we remove this bone out, and then after reduction of the fracture with the help of the F tools, my assistant is holding this fracture in proper position, and the guide wire has been introduced in the distal fragment. And after introduction of the guide wire, we are going to ring the medullary canal with the help of 9 millimeter ring off, and it is being ringed with 9 millimeter ring off, hand ring off. And it has crossed the fracture, and my assistant is keeping the fracture in reduced position throughout the nailing process with the help of the F tool. During nailing process also, it is kept in reduced position, otherwise there may be malalignment of the fracture. I am doing reading with a 10 millimeter remote, and still my assistant is keeping the fracture in reduced position, and I am confirming on the CR whether the fracture is in reduced position or not. And this is in reduced position, the slightly distracted, but in reduced position, in epi view, and also in lateral view. This is the oblique view. And also performing in the CR in both view, lower end of the femur. And finally, we rimmed this fracture with the help of power rim of 11 millimeter. Because the patient is old one, so rimming is easy. It is just to measure the size of the intermedullary canal, the diameter of the intermedullary canal. Can be prevented. And for proximal locking, and I am still making a hole in the floor to distance fragment and confirm in AP anesthetist and all the supporting staff for success.